Hi everyone, welcome to the Old School RN. Hope you're all well on this very muggy, hot day. I've just come to bring you back some news about what's going on in the NHS. As Wes Streeting, the Minister for Health, is doing a 10-year plan for the NHS. And one of the things that's come out of this review of the NHS is the legal title of nurse. Now, beforehand, anybody could call themselves a nurse. The title registered nurse, or RN, is protected by law, and that used to be, and if it's still the same now, you could serve up to 6 months in prison or be issued a large fine if you pretended to be a registered nurse when you were not. Now, the title nurse was more widespread, so you would get people who were struck off the national register, the Nursing and Midwifery Council register for nurses, and any man and his dog could literally call themselves a nurse and give the public that sense of, you know, I'm a qualified registered professional. No, they're not. Nurse has now become a legal term, a legal title that can end up with somebody who calls themselves a nurse having a massive fine, and they're mooting sort of thousands of pounds if somebody is caught calling themselves this. Now, I know a lot of the time in some of the aesthetic industries and other cosmetic, or they call them cosmetology areas, where people are performing medical procedures without a license, scars, taking off lumps and bumps, etc., etc. They were calling themselves nurses or health practitioners. You can't do that now. So that's a good thing. So I'm really pleased to see that people who've done the hard work, gone to get the degree and experienced, you know, hard graft in the NHS in various guises, excuse me, are now getting the protection and recognition that we deserve. You know, we work hard for our qualifications and pay for it as well. Okay, so that out the way, the 10-year plan. Now, the government, to me, seem to be going full circle. By that, I mean, Wes Streeting has mooted like how to address the population's needs over the next 10 years, particularly as we have an ageing population who some of the time will require more care if they've got complex conditions, diabetes, asthma, COPD, whatever. They're going to require chronic management, people with pain, blah, blah, blah. Now, back in the day, and I'm going back 40 years, people were managed in the community. We had community hospitals, we had our great GPs who did on call, who ran clinics from their surgeries, who went to people's houses. Guess what? Government wants to go back to that. So they've spent over 30 years dismantling a perfectly good system to go back to it again. And it is, in all but name, we're going back to how things once were. The only change is the technology. So now we've got AI, now we've got online consultations, which are fine for some people, but not all. This idea that, you know, technology can save the world. No, people are still going to require interaction and are still going to need that, you know, GP, doctor, nurse interface. It's a human thing, you know, you want to talk and discuss, and it's different if you need to see and examine a patient, because sometimes it can't be just, oh, show me your scar or show me this or show me that. Sometimes you have to be there with the patient. And then if an online consultation means we have to arrange another discussion, another consultation, a home visit or whatever, you're just doing everything twice. So I hope it'll be selective as to which group of patients we really need to look at for that. I think for healthier people, it's fine. You know, if I need a prescription for something quick, I can go online and speak to somebody fast, no problem. But I think in terms of elderly people and chronic illness, you really need to be face to face, because there are subtle signs that could be missed on an online consultation. Just to be thorough, you need to examine people, listen to their heart, listen to their chests, see what their skin rash is like in real time, not just on a screen. Anyway, so that's that. So addressing the needs of the population, here's hoping. The other thing the government mooted was addressing health inequalities, because there are health inequalities, particularly in cities compared to, say, rural communities. The services are very different, the needs are very different, and remote access to healthcare seems to be one of the issues, again, particularly for those who don't drive or who are very elderly or have a condition that means they're not allowed to drive. It limits their access to healthcare considerably. Conversely, in a city, it's crowded, but you have to wait for facilities. For example, A&E and mental health are just rammed. I mean, they really are, because everybody knows they're a last port of call if ever you need anything, from emergency contraception to meds for, if something's happened, like we get police who've been spat at by people who claim to have HIV. Well, those people need emergency care because they could develop HIV or be at risk of developing that. So it needs to be a fast-track service. A&E was never the catch-all for everything. A&E used to be empty because it was accidents or emergencies. It wasn't a one-stop shop to back up every other service. So that's changed considerably. And the waiting times are 12, 14, 16, 18 hours. I've known it longer than that. I've known a waiting room in one of our hospitals to be so full that the hospital had to divert because we were nursing patients on the floor. And that, I was there when that was happening. It was awful. And the impact on the patients is severe. So I'm glad this is going to be addressed, and that there are going to be more services available, hopefully, in smaller hospitals and healthcare clinics, community hospitals, for example. The prevention and promotion of health and lifestyle. Again, we're going back full circle. When I trained, and when many people trained before the year 2000, health education formed a big part of our role. We would sit with the patients, we would teach them about their medications, we would tell them what the side effects are and what to look for. We would give them leaflets and information and make sure they understood. We would go through their condition with them and show them and teach them how to manage it and how to keep on top of that when they go home. So they had access to, say, a heart failure clinic or the GP practice nurse. Nurses were integral to this process, and educating our patients was part of our role. It was a major part of our role. That's since sort of dissipated. One, because we're too busy, and two, the role of the RGN has become so narrowed now, down to just giving out medication and, checking pressure areas. I mean, there's a lot more to the role than that. It's a very wide level of training, or rather it was, that RGNs were pivotal to communicating with all the multidisciplinary team, the physios, the occupational therapists, etc., social workers even, that we collated all that care for the patient so that when they went home, they had access to home help, Meals on Wheels, both of which have gone, district nurses, district healthcare teams, physiotherapists in the community, occupational therapists in the community, GP home visits. We need to go back to that. It was a good service. It was perfect as it was, and it was so cost effective. But since all this dismantling and interruption and going back to, reinvent the wheel that was already there, to me just seems like a complete waste of time. Nothing in this plan is new, with the exception of the AI and technology, because, that is a new thing, well, to me anyway. First level support. So a lot of this will be support in the community to keep people at home so that they can be monitored and their observations taken at home. I mean, that's been going on for quite a while anyway, particularly for cardiac patients who over the phone, their pacemakers, etc., their heart rhythms can be monitored, telemetry, long distance telemetry. That's always been a thing, as it will be for many conditions. So I think overall the plan is reinventing the wheel. It's good that they're going back to that, because community services and district nurses were the hub, especially with the GPs on call who know their communities, were an integral part of what the NHS was about. Your GPs knew you, they knew your family, they knew your home circumstances, they knew everybody that they treated. You know, it wasn't just you see this GP, you see that GP, you know, it's all disjointed. There's no humanity. Today there is. I think if we can go back to that and have that friendliness, that professional support and that professional understanding whilst people are at home recovering, that would be marvellous. But it requires money. Removing district nurses and district services was the worst thing that could happen. Now, I know in maternity care, district midwives, some of them have been replaced by companies who now employ midwives, and I can get a feel that this is going to happen with district and community services, that instead of the nurses and the healthcare assistants being employed by the NHS, they'll be employed by, say, Virgin or some other care company. So that bit of me is a little bit sceptical. I'm all for change. I think improving on what you have is a good thing. But with the NHS, we haven't improved on what we had. It was dismantled and disintegrated when we already had a good thing in place. If we'd have had what we had 25, 30 years ago and longer, with the technology we've got, ideal, absolutely ideal. Bring back the home helps, bring back all those services, including chiropody and podiatry, particularly for the elderly, particularly for those with chronic conditions. Mobility is a big part of staying well, staying healthy. Exercise, walking. You can't walk if your feet have got diabetic foot ulcers, if your toenails aren't trimmed, if the skin on your feet is bad. You can't walk if you've got leg ulcers. You can't walk if you're not active. Luncheon clubs were a big part of looking after the elderly. They had somewhere to go. They would dance. Dance is perfect exercise for people staying mobile and healthy. It's the best exercise. Walking, brisk pace, not, you know, a slow stroll, is good for keeping those muscles going. And when you watch all these wellness videos and menopause videos, etc., and preventing falls, comes back to exercise and movement. Our elderly are not exercising and they're not moving because they're lonely, a lot of them, isolated, with very little to no family. So we've got to get back to that community feel. And I just hope that part of this 10-year plan is to invest in those services and communities and make us all a community again. So yeah, it's really strange, isn't it? We're going full circle to what we had before. I just hope that the private companies don't come in, because that's, well, the issues around that we already know about, don't we? You've got to have properly invested healthcare staff. Healthcare's a hard job for anybody working in it. It's emotionally draining, it's physically tiring, and if you're not being paid properly and your conditions are that you only see patients for 15 minutes and then drive to the next address, it's not going to work. People are just going to get fed up and they won't enjoy what they're doing. Part of looking after people is enjoying what you do. You don't go into healthcare just for the salary. Maybe some do. I know I didn't. I know many of my colleagues didn't. We did it because we love people and we want to look after them. But the NHS has got to put its money where its mouth is now. you know, and provide that care for people. I'm going to be doing some weekly videos now because I've had to arrange things around life, and it's been rather difficult. It's been ad hoc, sort of every couple of weeks, but I'm going to do regular features. One of those things is going to be on NHS news and events and things that are happening, and the other is going to be about what the private sector can do for you and help you in terms of if you want an alternative. The private sector has always existed. It's always worked hand in glove as a backup to the NHS, and it does have its uses. Privatising the NHS is a different thing, but whilst we've got the NHS, the private sector does offer a good alternative to people who either want to pay for it or have health insurance privately, or who have a work scheme to help them. So I'll be talking a bit about that, on how you can make the quality of your life better rather than waiting for years in pain or suffering with, you know, long-term conditions that could be treated more effectively in the private sector. So that will be my approach going forward from July. So I hope you'll join me, and thank you for watching, thank you for listening, and thank you for all your comments. Please like, subscribe and share. I'd be so grateful. I'd like to grow this channel and reach out to lots of people so that we can get them well and on their feet again. Thank you.